Thanks very much, Roger. Well, I was going to start with a disclaimer, actually, because although I was invited to give this talk, I'm not an expert in biofilms. So I'm afraid I've plundered the internet and various other people's work, particularly Steve Wilson, that was mentioned before. So to tell you about biofilms related to urinary prostheses. So this is what I'm going to cover in the talk. Firstly, define what a biofilm is, which I think you heard, those in the session on Monday might have heard a bit about that. A few illustrations of biofilms that we may know, how it comes about, and then relate it to the implantation of prostheses and perhaps how to prevent or minimize it. And also a lot of the work that's been done in material science, which is very much trying to understand the interaction between implants and microbiological organisms. So here's a definition. So here's the official definition, if you like. So it's basically a lot of microorganisms, so a mixed population embedded within a matrix that they make themselves, so mainly different polymers, particularly polysaccharides. So it makes a sort of meshwork that they can stick to and attach to around any implanted material. And it's a sort of evolving structure, so these organisms interact extensively to feed each other, to keep each other healthy within the community. And in particular is their ability to change their phenotype from a swimming around phenotype to a sessile phenotype, and to basically enjoy that life on an implant by collaborative growth patterns within the biofilm. I quite like this one. This is a bit more fanciful, sweet description of a biofilm, and actually it resonates with this picture of Manchester, doesn't it? So basically it's like a little city, and these big blocks are the towers of the microorganisms, and then there's little streets that channel nutrients and everything to keep the community going, just like Manchester, I guess. Mind you, the streets do sometimes look a bit like a biofilm walking around at night. So, biofilms we may know. So I've got a few here. So here's a biofilm, very pretty one. So this is mainly algae, which tend to fluoresce. And I don't know whether anybody's any tropical fish enthusiasts, but I did once have a fish tank, and this whole thing just went green, and you could just see a vague shape swimming around. So that was my tropical fish experience gone. Here's another one. So these are mainly staphylococci in a very sort of thin little matrix. So these all look healthy, and they're obviously collaborating with each other. And that's what we've all got on our skin, which obviously in hospitals we try and scrub off every 5 minutes, but they always come back again because the skin needs it to stay healthy. And that obviously has implications in terms of implants. And here's another one. So lots of little organisms within this network, and this is a pretty horrible picture now, but this is basically this is dental plaque. Obviously quite a bad case there, so that's why we try and clean our teeth and never get rid of it, obviously. And then the last one, and again this has got implications for catheters. So not very many organisms here, but quite a big network of polysaccharide polymers. And this is what you'd find in your U-bend if your sink got a bit blocked. And obviously that's very similar to what happens in urinary catheters. So there's some familiar biofilms. So it's quite well characterized now how these biofilms develop, and it's the same principles for all those biofilms I've just illustrated, whether they're on prostheses, whether they're on our skin or lining the cells of our gut or our throat or our respiratory tract. So anything exposed to the environment is going to get a biofilm onto it. So basically what happens, first of all, you can get a conditioning film on for example, on the implant, which is likely for a penile prosthesis to be a fibrin layer following some of the hematomal formation after implantation of the device. Whereas for a urinary catheter, where you've got the typical flow of urine, then it can be a more inorganic mineral conditioning film. And basically that both stimulates and allows bacteria to change their phenotype from a planktonic, which means swimming around type phenotype with flagella, So one that express lots of adhesions, which is those typical little hairy things on E. coli, pili, that tend to allow attachment to surfaces. So the first thing is a conditioning film, and then the bacteria attach to that conditioning film. Bacteria can actually attach even without a conditioning film, even in a very smooth surface. And then you get this sort of polymer. So these early immigrants, if you like, tend to multiply, and then they start laying down this polymer. And then that attracts other organisms, so different species. So you can get a very mixed population of gram-negatives, gram-positives. And they actually talk to each other by a thing called quorum sensing. So this is messages that the bacteria give to each other, to make sure they're friendly and make sure they cooperate rather than try and push each other off. And then that basically grows into a mature biofilm with a stable population at the base, lots of polymers, and then a more fluid population at the top where the bacteria are coming and going. So this probably doesn't matter very much. So if you remember this type of picture, then maybe that's okay. It's when you get this that obviously then you get signs of infection because of the bacteria being let loose into the surrounding tissue. So in the case of a urogenital prosthesis, so this is a pump that's been removed because of infection, and you can see there's all things gummed to it, a bit of fibrinous exudate and all that sort of stuff. So that's obviously the conditioning film that then the bugs have attached to. So with penile prostheses or artificial urinary sphincter, obviously they're implanted through skin, which is a high commensal population, so it's inevitable really that they're going to be contaminated with skin commensals, which then will attach particularly the coagulase negative staphylococci. And so the priority is probably, rather than worrying too much about these, is to avoid contamination by more prolific or aggressive phenotypes, particularly E. coli and other bugs that do cause more active infection. But we certainly do need mechanisms to both minimize contamination with skin organisms and also to avoid getting any of these nasty bugs into the device, which would inevitably mean its removal. So what we do currently, well, the first thing is to try and minimize contamination. So obviously every surgeon who puts these implants in has a strict regime of decontamination of both themselves and the patient, and in some cases the device. The second thing is to try and stop that conditioning film, which in urinary implants is the sort of hematoma and fibrinous exudate that you're going to get around the implant. And the key to that, as we heard from Tim Terry, with the good implanters, you can implant a penile implant in 35 minutes. So reducing the time, reducing the tissue trauma, using small incisions, avoiding hematomas, using drains if necessary, or at least trying to minimize any hematoma. So they're all important to try and minimize the inflammatory response. And then if there is infection, for example, urinary infection, that tends to try and needs to be treated. And obviously any skin lesions, but actual skin contamination, then the jury's out, in whether that does more harm than good. And certainly the current thinking is that skin contamination should be done just before implantation rather than a long period beforehand. And then one of the last innovations on these implants, particularly the AMS ones, has been the coating of the implants with a mixture of rifampicin and minocycline. And according to the reports from AMS, and a lot of this does come from Steve Wilson's work, is that tends to minimize the slow chronic sinus infection type formation that eventually leads to removal. So it tends to reduce that, but it doesn't seem to reduce the more aggressive infections that mean instant removal. So it has changed things for the better. So it probably has reduced the risk of removal of the implant due to infection. So what about future prospects? Well, the main thing people are working on, and this applies to huge numbers of different biofilms, because obviously it's a big problem with industry, with block pipes and things like that, ships building up biofilms on their hulls, all sorts of things. There's a lot of technology and material science going on. And really, one of the thinking is if you can encourage a stable population of relatively quiescent organisms, as a biofilm, then maybe that's better. Rather than trying to eradicate it completely, because that's probably going to be impossible, you've got to try and induce a stable population. So you can sort of try and put a layer of bugs on there that will inhibit other bugs coming and taking part in the biofilm. And there's a lot of work going on about how bacteria interact and how you can prevent them interact. And some things that can be tried is trying to inhibit bacterial adhesion. Some bugs create surfactants that discourage other bugs attaching to surfaces, so basically detergent on the surface. You can get this quorum sensing where bugs communicate with each other. You can some bugs secrete inhibitors of that, which again gives a mono organism population, which is perhaps safer, particularly if it's one that stays attached, to try and stop this business where the bugs continually shed and are likely to cause infection, clinical infection. So one thing you might be hearing about is surface, so again material technology. So in the past the key was to try and create a smooth surface. That was why there's so much excitement 50 years ago with this silicone, because it's quite a smooth surface compared to latex, which has a number of random imperfections. But more recently it's been found that if you have regular imperfections, so this is sort of nanoparticle science, these are under very high EM magnification. So this is so-called shark skin, because this came from an idea that sharks don't seem to get barnacles, whereas whales do. And if you look at the difference, shark skin has got this type of microscopic pattern. So this is already being used in technology, both in shipping, but also more recently in catheters. So there are some catheters coming out with this type of surface. So that could be another innovation for implants. So that's changing the properties to try and inhibit biofilm formation by altering the structure, nanoparticles, or changing the charge or the degree of wettability. And then there's anti-biofilm agents that I mentioned, so surfactants to try and wash things off, quorum sensing, and maybe population with good bacteria such as the coagulase eggs, staphylococci, that are unlikely to result in clinical infection. And these are some of the mechanisms using either the host or the invader to try and minimize the unfortunate effects of biofilms, particularly symptomatic infection. And then also, particularly in joint surgery, then there are some physical methods, for example, low-frequency ultrasound. So when you implant a hip, then you apply low-frequency ultrasound for the first few days to try and discourage formation of the biofilm on the conditioning film, and the same thing by altering the charge. So all these mechanisms are being explored. As I say, most of these uses in industry and then get translated to the prosthetic field. So in summary, the current surgical approach probably makes contamination inevitable because you're going through the skin. And really you just got to try and minimize this as far as possible. In actual fact, the infection rates, particularly for artificial urinary sphincter, are extremely low. I mean, in our practice in Newcastle, I can't remember when we had a primary infected artificial urinary sphincter prosthesis. The primary infection in penile implant is higher, perhaps because of the increased trauma of putting them in. So really you want to try and know what the best practice is in terms of minimizing that contamination, particularly of the more aggressive organisms. But in the future, probably it is going to be more smarter materials from the silicon that's been around for many, many years now. And it is really surprising how little these devices have evolved over the years. So all that is hopefully to try and avoid the horror of the surgeon when he's faced with an implant. So here's the ultimate biofilm. So you can see this sewer worker is pretty shocked at what he's seen. So this is the fatberg that we're hearing more and more about, particularly down in London, isn't it? So that might be the ultimate biofilm. So thank you very much. I hope that's been informative. I certainly enjoyed researching the talk. Thank you very much.
So thank you, Rob. Whilst anyone coming forward for questions, can I just ask, so do you think that all prostheses form a biofilm, and it's just that in some the interaction is such that you end up with erosion and needing to explant the prosthesis? Or do some not form any biofilm?
Yeah, so Steve Wilson's work again in his group, where they revised implants for mechanical malfunction, they swabbed all of them, reasonably rigorous microbiological methods, but they all had coagulated negative staphylococci on them when they were explanted without any clinical evidence of infection. So I think when you're implanting something like that through the skin, it's inevitable you're going to get a biofilm, I would have thought. But
so we're just
keeping it quiescent is the key.
Yeah. Okay. Thank you very much. Any more questions from the audience? Yes, someone at microphone 3, I think.
Do you think patients with recurrent cystitis that have a sloughy bladder wall create biofilms in the slough? And is it worthwhile cauterizing the area to try and encourage normal urothelium to grow?
Yeah, so as you may know, there's a lot of work looking at the influence of biofilms on different diseases. So a healthy human, we've got biofilms everywhere, on our skin, in our gut, obviously women in the vagina. The bladder, a little bit uncertain. Obviously some work does suggest that the bladder does have its own microbiome, certainly the urethra does. And then when it becomes visible, then that's the later stage where it's obviously gone a bit crazy, maybe because of a mixed bacterial population, and it's producing a lot excess extracellular matrix. And this is all anecdotal, but we do see occasionally younger women with extensive plaque formation around the bladder, and certainly I have resected that, and they do, it does seem to be benefit of clearing the excess biofilm. But really then you need the next treatment to re-establish the normal biofilm, if you like, don't you? Because obviously the trouble is it just comes back again if you don't eradicate the particular population of bacteria that's caused that problem.
Do you then follow it up with, say, cystostat or Ioluril?
Yeah, we have done. I mean, obviously we're talking 3 or 4 cases over 5 years or so, and we do tend to follow it up with that to try and encourage it. I must admit that's gone both ways. So some seem to then get an even more aggressive biofilm following the cyst or a hyaluronic acid treatment, whereas some it does seem to go back to a macroscopically or endoscopically normal state and lack of symptoms.
Thank you.
Thank you very much, Rob.
Cheers.